Prior to initiating the neonatal neurological examination, it's important to determine the gestational age of the patient and if the patient is on any sedative medications or has had a history of seizures, which may alter the exam findings. The patient being examined in this video is a term baby who was born 72 hours ago and is completing the last 6 hours of therapeutic hypothermia during the examination. The patient has been sedated with dexmedetomidine 0.05 micrograms per kilogram per hour throughout the hypothermia for shivering. There were no seizures and anticonvulsants were not given. The patient has a body temperature of 33 degrees Celsius at the time of the exam and thus may appear hypoperfused. The patient should be examined on a flat surface, free from confining rolls and restraints. The head should be in midline position. Excessive noise should be avoided during the examination. Neurological exam includes the assessment of level of consciousness, head and face examination, assessment of cranial nerves, primitive reflexes, axial and peripheral muscle tone, and deep tendon reflexes. The most important part of the examination is observation of the patient. Observation should be made with as little disturbance to the infant as possible. Items of the neurological examination don't have to be in any certain order as long as they're all covered. Parts of the examination that require the greatest degree of disturbance should be elicited at the end. Spontaneous movements and resting posture should be observed first, then how the patient responds to handling, touch, and manipulation. Preterm infants tend to have extension posturing due to lack of cortical inhibition of extensor muscles, and with maturation of gestational age, flexor muscles become more predominant. This patient demonstrates normal posture and tone at rest with the arms and legs flexed and proximal to the body. In order to assess the level of alertness and muscle tone properly, the baby has to be gently transitioned from sleep to wakefulness. This is demonstrated initially by gently touching the infant's feet. The infant is then moved to a seated position to see if the eyes will open or the patient will cry in response to touch, and she does that quite nicely. During crying, note whether the face has any facial asymmetry. The next part of the examination is the examination of the head, face, and eyes. Start with the size and fullness of the fontanelles and move to the occipital region to examine for bogginess, which could represent caput secundum. If the ears are bulging with shifting of the ear lobules forward and the occipital region is boggy, these findings would suggest subgaleal hemorrhage. In cephalohematoma, the swelling would not cross the suture line. Cranial nerve examination in the newborn can be elicited through the facial reflexes. Observe for facial symmetry of the mouth, eyes, nose, and ears. Check the rooting response by rubbing gently on the patient's cheek. An awake and hungry baby will turn in response to this action. This patient remains in quiet sleep at this time. It's important to reassess the patient when he or she is awake and active. Normal rooting reflex indicates integrity of the trigeminal nerve 5. Check the sucking response with a soother or a gloved finger. A normal baby will suck vigorously when the soother is placed in the mouth, demonstrated here as an initial response, but it's not consistent. Normal sucking reflex indicates integrity of trigeminal nerve 5 and 7. Blinking of the eyes in response to light indicates the integrity of optic and facial nerves 2 and 7. Check the pupillary response for symmetry and briskness by shining a pen light in the eye. Pupils should briskly constrict to light symmetrically as seen here, which indicates the integrity of optic and oculomotor nerves 2 and 3. Examine the axial tone by first checking for head lag by pulling the hands gently to a sitting position. The patient who is hypotonic will have poor head control and will need support. A normal newborn will be able to bring the head in line with the body. This patient demonstrates some head lag. Another way to measure tone is to hold the infant in vertical suspension. They should not slip through your hands when held under the arms in the shoulder girdle, as demonstrated here. In ventral suspension, the patient should not curve over the hands as shown here, but should display some stiffening of the arms and legs. With the baby in this position, the Gallant reflex can be assessed. In this reflex, scratching of the skin on the infant's back from the shoulder downwards, lateral to the spine, results in a curving of the trunk, with the concavity on the stimulated side. It normally disappears by 4 months of age. Persistence of the spinal Gallant reflex leads to a delay in motor function, difficulty in sitting, and sensory hypersensitivity. The stepping or walking reflex. Baby appears to take steps or dance when held upright with his or her feet touching the solid surface. This reflex usually disappears by the end of 2 months. This baby has not demonstrated this reflex. The ATNR or fencing reflex, also referred to as tonic neck response, is demonstrated when the head is turned to one side and the arm on that side is extended with the contralateral arm flexed. The ATNR may not be present in newborns after birth but appears after 2 to 3 weeks. The reflex is most prominent during the second month of life, and infants may assume it spontaneously. Problems associated with the persistent ATNR after 3 months of life are inability to roll, crawl, balance problems, poor hand-eye coordination, and vestibular issues. Peripheral muscle tone is measured in each limb independently by manually assessing both sides spontaneously as seen here. Arm recoil is a sign of maturity and integrity of the muscle tone as shown here. Tone can also be assessed by moving the arms across the body. This is called scarf sign. In a term baby, the biceps should not be able to cross the midline, as shown here. In addition to full range of passive movements, another way to measure the muscle tone in the lower extremities is assessment of the popliteal angle. With the thigh fixed to the body, the leg is extended and the angle is measured behind the knee. This is usually 90 to 120 degrees in a normal newborn. A wider angle indicates low muscle tone. It's important to compare the measures from one leg to the other to rule out unilateral lesions in the case of a focal brain injury. Another neonatal reflex is the grasp reflex. The patient should grasp your finger when it is placed in the palm of the hand as shown here, with the right side being stronger than the left. Persistence of the palmar grasp beyond 3 to 4 months of age can later cause difficulty in releasing objects, difficulty in fine motor activity, and sensory hypersensitivity. Deep tendon reflexes are measured with a reflex hammer, using the weight of the hammer to elicit the reflex in the biceps and brachioradialis in the upper extremities, as shown here. Deep tendon reflexes in the lower extremities include knee or patella reflex, cross adductors, and ankle reflex. This patient has cross adductor spread, where movement of one leg occurs when the other leg is tapped. Exaggeration of the deep tendon reflexes is seen in cases of upper motor neuron lesions. Absence of deep tendon reflexes occurs in some of the neuromuscular disorders. The plantar grasp is shown here. This patient's toes curl over the examiner's fingers when the finger is placed on the plantar side of the foot behind the toes. The plantar response, also referred to as Babinski, is normal when there is dorsiflexion of the big toe, plantar flexion of the small toe with fanning of the toes upward in response to stimulation along the dorsal aspect of the bottom of the feet. This patient does not demonstrate that response at this time. However, the reflex can only be elicited when the patient is alert and active. This response beyond 24 months of age is abnormal and indicates injury in the corticospinal tracts. To check for clonus, briskly dorsiflexing the foot should elicit clonus if it is present. There is no evidence of clonus in this patient. The Moro reflex is elicited by providing a falling sensation. A full response is demonstrated when there is full abduction and adduction of the arms, followed by a cry. Here we see a partial Moro response because there is no cry. If the reflex is present beyond 6 months, this can lead to various neurological abnormalities in children, like vestibular hypersensitivity, poor eye-hand coordination, balance insecurities, and visual hypersensitivity. In general, primitive reflexes are complex, automatic movement patterns which are thought to be brainstem mediated. They start around 25 weeks gestation and are fully present at birth in term infants and integrate during the first few months of life when cortical inhibition emerges and when voluntary motor activity takes over. They are considered part of sensory motor development, allowing the infant to practice anti-gravity movement in preparation for voluntary movements. Thompson's scoring for assessment of the degree of encephalopathy was found to have a strong correlation with long-term outcome, especially in the assessment done before discharge. Reviewing the history and examination of this patient, the Thompson score was 2 for hypotonia, 2 for lethargy, 0 for no seizures, 0 for normal posture, 1 for partial Moro response, 1 for weak grasp, 0 for normal suck, 0 for normal respirations, and 0 for normal fontanelle. The score for this case is 6, which indicates a mild degree of encephalopathy. The score on admission for this patient was 2 prior to the administration of any sedating medications. In summary, this is a term baby with HIE who's undergoing therapeutic hypothermia and is still mildly encephalopathic on examination at 72 hours of age, but sedatives may be contributing to the findings. At the time of discharge, by 5 days of age, the patient had a completely normal neurological examination and was orally feeding without difficulty. The MRI was obtained on day 4 of life and did not show any abnormalities. The prognosis for this infant is favorable for a good neurodevelopmental outcome. For more information regarding assessment and treatment of infants with encephalopathy, please see the linked guidelines and challenge yourself by working through a clinical case of an infant who presents with HIE.